Hey everyone, this is the Manips and Sips podcast featuring Dr. Jeremy Boyd, that's me, and Dr. Brandon Cruz over there. Today we're going to be continuing our discussion on ACL reconstructions and the rehab. We kind of left off on the early phases or the first couple months of rehab. So we're going to pick up where we left off and keep trying to provide some what we do and some information and some research on progressing these clients. But before I get too much in the weeds of it, how's it going, Brandon?
Going well. Thanks, Jeremy. Real quick side note for you sports fans. I'm actually wearing my cowboy gear here.
Oh.
Except I just found out we signed Dak to a ridiculously awful contract, like $175 million.
Really?
I just don't think he's worth that. He hasn't done anything yet.
So you're stuck with him for
fans
years.
Out there, let me know how you feel. Any Giants fans, I don't need your feedback. Thank you. But with that, I'm finishing off my drink today. Last of my Bib and Tucker. I have to go restock because that actually became one of my favorites. Jerry, what you got today?
I have American Solera, Terpy Galaxy. It's a double IPA, 8%. So again, if I get a little funny towards the end of the podcast, you guys know why. I've never had this. I went to pretty much a craft beer liquor store, and the guy was like, "You have to try this." Showed me a picture of what it looks like, and I was sold on it. I'm drinking it from the Red, White, and Brew beer company, which was the last brewery I went to before the pandemic hit. They just started, so I hope they're doing well. But really cool breweries and an old bank, so the old-fashioned vault with the spinning lock sort of thing. So
nice.
They redid it. They kept it all, so it's pretty awesome. But let me get a sip of this bad boy.
Nice. Jared, next time, I think you need to start getting your slow pours in the shot here, man. It's looking luscious when you do it.
I'll do that next time.
There we go.
And the beer is luscious. That's something sweet. I'm trying to look up if it had anything of actually what it is, but kind of got a flowery kind of. Let me get another sip here. Hold on.
Yeah, take your time, man. We need the juices flowing correctly for this episode.
It is kind of a juicy, more of a juicy double IPA. Pretty good. As I said, I've been kind of in the double IPAs of late. Thanks to Bonesaw by me and their squeeze-ins, but pretty good, pretty delicious. No description of exactly what's in it, but I'm a fan of it. Let's talk. Let's talk more about ACLs. All
right, just to kind of circle back and recap on what we talked about last time. I'm going to share this. Derek, can you enable my screen sharing here?
Yeah, sorry.
We talked mainly in the first episode. We decided to split this one up into like a two-parter because the first podcast we did about ACL part one really focused on surgery and the initial phase, which is kind of that return to ADLs and return to work, and what we should really focus on that first, 4 to 6 weeks after post-op, attacking range of motion, especially extension, and attacking those quads. So that's what we kind of talked about last time. We're now going to kind of jump into the rest of our progression, which would be, that month 2 and 3, which is like that strength phase, leading up to that return to running. 3 months seems to be that kind of gold standard there where everyone wants to return to running at 3 months, and then some additional testing leading up to or the phases between running and returning to sport. And I think that's where things don't go as well as we want to. If you guys remember some of the stats last time, only about 55 to 70% of patients return to their pre-level of function or pre-level of, ability to return to sport at their prior level, which for a surgery that's probably one of the most in the country, at least here in the U.S., is not that good of a success rate, in my opinion. And I think, Jeremy, you share that same sentiment. So I guess, can we question some things today and what's out there, and just, not go by the standard protocol that is out there. Joe, your thoughts on that?
Yeah, and even the most performed, surgery, and obvious. I think it's also the most, as we discussed last time, the most researched one. So we are clearly not doing a good enough job, and I think that does fall more on the rehab side of things. Obviously, I recommend that those surgeries that is a very complex surgery and should be performed by someone who all they do is ACLs. I think there was I didn't know the conversation would go that way. There was a research study about almost general orthopedists who just perform ACLs here and there versus ones that do it more frequently. And obviously, if you practice it more, you tend to have better outcomes. But in your smaller towns and those sort of things, you may not have access to a more specialized surgeon. But beyond that, this is where it comes down to onto rehab. We talked about before. James Andrews says, it's really on the rehab to get the job done, and kind of highlighting, how well the job we do. But I think we need to do a better job of things. So, as you say, it's not just following just basic guidelines and stuff. Well, how can we take it the next step further? How can we really base it off of specifically to our clients? We're seeing things like apps that can do our rehab for you, or some surgeons say, hey, you don't need that much. I saw one study, it was like, oh, you need one session for every 6 weeks with ACLs or something of that nature. That's you're giving these apps, and that's very cookie cutter based. And if you work with ACLs long enough, especially in those early phases, some may be flexion machines and can get a lot of it and suck with extension, and vice versa. Some may have quad control, some may not. So not to kind of get into cookie cutter things, because everyone's a little bit different. But yeah, well, a little tangent there.
It's good. I think aside from, the cookie cutter and the protocols, I don't know about you. I really don't follow those protocols anymore. I mean, they're there just to make sure we're on a timeline to adhere to the surgeons. But other than that, I'm going to do what I need to do to get the patient where they need to go.
Absolutely.
And I mean, personally, I'm not huge on post-ops, because to me, they're, I don't want to say they're boring, but they kind of are. If you're taking the viewpoint of, oh, I love post-ops because I get just to follow the phases, well, then you're doing it wrong, to allude to your point there, Jer. And I know you had the phases there, so I want you to shoot up that phase there, and then I want to transition the talk to utilizing and obviously strengthening and attacking the quads and hamstrings, but your thoughts on use of NMES, and for those people who have those lazy quads, should we use it for all patients, some patients, no patients? So after you shoot this up, what are your thoughts on that one?
Yeah, I agree with you. I kind of don't go crazy with protocols or anything like that. Actually, most of the surgeons by me with ACLs, they're not really, their scripts are just as basic as they've always kind of been. It's now like typed out ACL, blah, blah, blah. And almost kind of to the point where I don't know if they just trust PT, or maybe it's my clinic or whatever it may be, and they don't, and they trust that we're progressing them appropriately, which I like that. I mean, I always like to take a respect. You should always get the surgical report. You can find out a lot more is done, and you do need to take that into account there. But to solely rely on a protocol, you're doing your client a disservice. I've had some people that have blown past protocols of how quickly they respond, and vice versa. And if you're just basing off of like the time of protocols, you can be really screwing some people up. If you're like especially an entry level or maybe a student physical therapist, and you don't have any like real experience with ACLs altogether, or the phases, and this just sounds like you're like a deer in the headlights to you in regards to these phases. A good article is the recent advances in rehabilitation of anterior cruciate ligament injuries by Kevin Wellick and McCreaney and James Andrews. They're the big ACL guys. It's in 2012, so it probably can be updated because the procedures have vastly changed. Hamstring autografts have become more popular. We're now seeing them adding an additional, I guess a tether or string to the ACLs. We're seeing ACLs trying to spare the original ACL. So things have changed quite a deal, but, similar kind of goals. All right, we want full knee extension. They're varieties of getting knee extension, proprioception and balance, more balance drills and those sort of things. We'll talk a little bit about the strain of open kinetic chain versus closed kinetic chain on the ACL. What would be better? We can talk more about these sort of things. Criteria for return to play, and again more. This is about what graft is the best. We can talk about that too. But if you scroll all the way down, then we have an accelerated rehab protocol. If you really just don't have, for a patellar tendon graft or a bone tendon bone, if you really just don't have any sort of thing to kind of work off of, this gives you goals, criteria to get to the next level, some basic exercise. Again, a little bit obviously cookie cutter. The goals should be, I guess, not so cookie cutter, but the exercises and those sort of things, that's, they're trying to generalize it to a whole public here. But it gives you like post-op day 1, post-op day 4, the 7. We talked about, the controlled ambulation phase, and now we're kind of talking about this advanced activity phase. So a really good, just a basic sort of thing to kind of get your head wrapped around if you just really don't have any experience. But going back to what Brandon was talking about with, NMES, that first sort of thing is, quad control, quad. What is my kind of opinion on it? Early on, I think anyone at ACL didn't matter. They were going to get their, 10 minutes of 10 seconds on, 10 seconds off. ACL full extension, which I know kind of goes against what the research says, because it should be like 45 to 90, at 45 to 60 degrees. And I just did it again, kind of cookie cutter, wasn't thinking, didn't really put any thought to what the client needed specifically for them. Yeah, sure, it can help. It can fire up the quad, if their quad's already cooking and it's already good and they can contract it, they can control it, they have a good Q score. Do they need more NMES? Do they need a supplement to that quad? It's almost like, taking pain medication when you're not in pain. You're not really helping the brain out in that case. Maybe that person needs more knee flexion at that point. Why don't I spend those 10 minutes regaining knee flexion or doing joint moves or working more balance and those sort of things? So I always, every minute's precious in the clinic. So not unless it really is a sleepy quad. Mm-hmm. We can't get it going. I'm not seeing much of a contraction at all, or it's very easy, fatigable. Am I throwing that NMES in? But what about you, Brandon? What's your strategies?
Yeah, I agree. I mean, I think early on, I actually took the stance opposite, where I didn't want to, I thought stim and all forms of stim were a waste of time or something that they could do on their own. And even to this day, I try and focus most of the treatment on, higher quality and, active or manual therapy as possible. I'll try and order, if their insurance allows it, where they can get one of those portable stim units at home and instruct them how to use it and spend some time. But like you said, those minutes in the clinic are precious. We have, 3 hours, maybe 4 hours max with the patient. And that's not even with the patient. That's that they're in the clinic. Most clinics are, very busy, where they're seeing 4 or 5 an hour. So how much time are you actually get with the patient? I'm not trying to have the patient sit on stim, ice, heat, or some other passive modality for most of the time. I want to be as effective as possible. So there are times I've spent a majority of the session having them doing the most low level exercise, but they're active and they're being watched like a hawk to get that quad going. Because in my opinion, that the NMES is, can be a crutch for some people. Don't get me wrong, like you said, there are some people who need it, and I think that takes some time to try and identify those people who are going to be some problem in getting that quad going, versus some people, they respond, like you said, right away. They're ahead of the curve. And I know you brought up Adrian Peterson last time. I guess rumor has it that he had a quad contraction and a straight leg raise a couple hours after surgery. I mean, that's not most people, but there's clearly some neuromuscular rewiring there that he and other people can probably progress faster than maybe the average person who's not an athlete but plays a sport. I think there's a difference between an athlete versus somebody who is an athlete because they just play a sport and maybe not a natural gifted athlete. And I think that goes into mindset and neuromuscular capability and coordination and all that other stuff that we're not going to get into right now.
Yeah, and we got to take into account, especially with those individuals, like genetics and those sort of things. Their muscles are ready to rock and roll more than anyone else. So, but yeah, I think we're on the same boat with that. But go ahead, Brandon.
Yeah, you had just showed, and especially for clinicians who are either new grads or students or who just don't have a lot of, maybe they're switching settings and they don't have a lot of experience. I mean, go to the APTA practice guidelines. They have nice resource here. Share that for you guys of what to look for and implementation, and should you be looking at what things you could be doing towards flexibility or strengthening or running and core. They give you timelines. They give you the up-to-date research. They talk about the PEP program, which is really more of a preventative thing or a warm-up thing for people or teams, people coming out of sports, what they should really focus on. And we'll get to that aspect later on in our conversation today, Jer. But I just wanted to share that as a resource for other people that, the APTA is a good resource. I hope you guys have your memberships. If you don't have a membership and you're a PT, I don't know what you're waiting for. They have valuable resources. People say they suck, and they may have their shortcomings, but they also have a lot of resources if you take the time to look. It's just taking the time to look and navigate and read through this stuff. And I know a lot of people want things handed to them on a silver platter, but yeah, a lot of stuff is there.
Yeah, it's
I guess
conversation for another day.
Yeah, I guess we should, let's transition to, I guess, weight bear, closed chain versus open chain exercises, when to do them. There's, different people stand on the fence, different side that you can do open chain, kind of off the jump, or once they have a quad strength and quad control. Some people want to wait until 6, 8, 12 weeks out or whatever the case may be before they initiate. What are your thoughts on that? I'll share some articles in a bit, but yeah, what do you think, Jer?
Yeah, so I know there, especially when I came out of school, there was a big knock on kind of open kinetic chain on the potential strain that it can cause on the ACL, which may cause one, more pain, and then obviously potentially increased laxity on the fresh graft. Mm-hmm. So I'll admit that it's like I'm pretty sure I'd lead a lot of my ACLs almost their entire program from start to finish. Or we're talking about months, return to sport, where they didn't touch an open kinetic chain exercise. Simply because of that. They seem like they did okay and well, and that's good and all, but obviously at this point I want the best and shoot for perfection with all the clients. But there's nothing, especially the biggest problem post ACL, if you sum it down, is probably loss of extension, but ultimately quad inhibition, and there's nothing that can quite get the quad going more than open kinetic chain exercises. Work out in the gym and for a while, just stick to like squats and, lunges and stuff like that. You'll get definition to your quads, but spend some time doing leg extension machine, and that's how you get the really yoked up quads. But
Teardrop.
so yeah, teardrop. So there's definitely a place for it. I do tend to wait a couple weeks, unless there's really, someone who's got one of those quads that just aren't waking up. People can visualize and see. And at that point, we've probably tried a lot of the close chain exercises, the NMES and those sort of things. But if it's really just not working, it's still weak. They're still like, not confident with walking because their quad can't hold them up in like stance phase and those sort of things, then you really need to throw in that quad, those open kinetic chain exercises like your LAQs or knee extension, your SAQs, to really build up the strength of that. Because if not, they're just gonna not be so confident with it. But
yeah,
what about you, Brandon?
Yeah, I think we talked about this last podcast where the long-term quads inhibition, and you alluded to deficits. I mean, they're alarming, anywhere from 13 to 44% at 1 year and 4 to 21% at 2 years. Hamstrings not too far off either, anywhere from 5 to 18% as well. So I definitely use it. I like my long arc quads or knee extension machine. I mean, there are ways to help mitigate that those forces if you're worried about the integrity of the ligament. Like you, I wait until they have a good quad set and at least zero extension before I'm doing that. But those last 5 degrees of motions, when you get that VMO and that screw home mechanism, if we're going biomechanically, this article by Camellia, Wilk, and Andrews in 2012 talk about moving up the pad, up the shin, away from the ankle to just shorten that lower arm and stress if you're worried about that. But there's still benefit in getting, especially from, I guess, 45 degrees to 0 degrees is really where that quad's working the most. And I think some people even say between 10 and 50 degrees is where like the peak forces and I guess activation are occurring. So, be mindful of those ranges when you do it. I'm worried about that terminal knee extension. Are they able to lock out and maintain that lockout? So I'll have them hold that for like 3 seconds or 5 seconds sometimes with their long arc quads or knee extension machine, just so that muscle can get used to holding and locking out and not giving way as soon as they reach that, because they're going to need that when they're running or when they're walking to be able to maintain and kind of lock out at 0 degrees or whatever their normal knee extension range is. So I don't think we should overlook open chain and poo-poo it right away, throw the baby out with the bathwater. But with that said, and I think we should probably transition, is what is our strengthening looking like prior to running? Are we doing double leg squats, single leg squats, deadlifts, RDLs, things like that? And that's probably transitioning from phase 2 to phase 3, I guess, with our prolonged strengthening.
Yeah. Did you want to put up that article? Did you have it?
Yeah. Let me get it real quick so
people can see it.
Yeah.
But yeah, as Brandon, as our conversation kind of transitions, what we do before running is, you got to think running is, I think I forget who put this way, is controlled falling.
Okay.
Over and over and over and over and over and over. And it's a pretty high level thing when you think, if you break it down in slow motion, they're fully extending their stride, their legs, they're landing on one leg, they're balancing, controlling on it while they're running with, force and speed. So our therapy prior to that needs to kind of prepare them and replicate those sort of things. So I know, and I'll pull up the article um, about how we just assume, at the typically the 3-month marker is the running frame. That's what all the clients come in. They're like, my surgeon said at 3 months I'll be running.
Yeah.
Um, and I'm like, that's great and all. That's something that we shoot for, absolutely. But it's not just 3 months because of healing timelines. It's hopefully you're also hitting some criteria.
Mhm.
You're having good strength of your quad and your hamstrings, as Brandon mentioned before. You have good balance and control. You're confident. I know some people, I mean, like ACL groups and those sort of things, they're still walking funny at 6 9 months. Like, well, you should have probably been running at that point. So obviously, I take it to whatever the client can give me. Somewhere before we start getting to the more advanced strengthening, I'm doing advanced balance drills, like single leg balance, kicking a soccer ball while balancing on the operative leg, kind of getting them a feel for more of those advanced, more higher thought process exercises versus, just like something like a straight leg raise and
Those
heel
feedback,
slides
feed forward control mechanism.
absolutely. And then from there, I'm going to try and transition towards, um, single leg RDLs and those sort of things, working a control component, but let's start adding some strength. Starting off with our, squats, getting to goblet squats. If there's no shift or anything like that, then, going from box squats and to, barbell squats. So, yeah, it may not be a ton of volume in those sort of things, but in reality, they have to have a good amount of strength before they start to get into running. I'll put up the article about, how most of us are not really putting up, or not testing enough before running. But
Mhm.
what about you there, Brandon?
Yeah, I'll get to that in a second. I am going to disagree with you a little bit, or maybe challenge you a little bit,
I
or
like
we
it.
can have a
I
little
like it.
debate here. I'm not huge on the whole balance activities. Um, I think we, as a profession, I'm talking globally, and this is going from what I've seen, what I've been around. It's you toss them on an AirX and you have them do all these balance exercises, and what's that really doing? And if you have a rationale for it, then great. But if you're just throwing them on an AirX, but I'm not saying you, I'm just saying out there. Um, to me, your balance is coming from strength and control, both concentrically and eccentrically. When you talk about running is a plyometric activity over and over and over again. You were talking about the forces. I mean, we've said before, it's like 7 to 10 times your body weight. 7 to 10,000 newtons of force being placed through it. If you don't have, the appropriate range of motion and strength, what's really going on there? So I like to focus on, my progression of double leg exercises, double leg RDLs, with a hinge style. So we're really targeting those hamstrings, to prevent and add a buttress to help support the ACL. And then the double leg exercises like lunges and squats. I love lunges. I think it's a great single leg exercise, or split stance exercise, where you're getting that concentric and eccentric load, and you're getting a balance kind of point as well. But if you can control a step down and a lunge, you can control running. So I really try and focus my activities on those type of exercises, single leg RDLs, when they're appropriate, step down exercises loaded, and lunges as kind of my balance ish activities. But you're getting that eccentric force, that concentric force, that feed forward and feedback mechanism, before I go into that as well.
Yeah, so I do have, I guess, a rationale for it. I know also if you look at the power balance exercises, um, their effect on power, they actually result in a decrease in power.
Okay.
That study, obviously, it doesn't look in like, oh, well, if we, did balance or proprioception, plus power exercise, which my program encompasses a lot. We have like a glute activation, core activation. We try and get a powerlifting movement, an Olympic lifting movement, balance, and then return to sport exercises. That's kind of how I frame some things as people start to get more and more advanced. But in those early stages, it's more probably I do that more for a confidence sort of thing.
Mm-hmm.
A lot of them, with those double-legged exercises, we'll start to see weight shifts.
Correct.
We'll start to just see them pushing off or just using their non-involved leg. So me getting them to do some more balanced stuff, them focusing on that one leg. Balancing on one leg, we're further enhancing that, first co-contraction, quadriceps, hamstring. You bend the knee a little bit. It modifies some things. If they still have some quad deficiency, have them doing full knee extension. But then I can start to throw in more with the single leg balance and those sort of things. Some components of their sport. Can you do some of the squat and throw a ball at them? Yeah. But that's just more of a psychological buildup for them, is where, all right, I have a hockey player tore his ACL. He's balancing on a pad while playing around with a hockey stick. It's just more some sort of thing to kind of get them back into like, oh, wow, I'm not that far away. At that point, that 2-3 month marker, that's where the mental fatigue and drains come in. So if you can kind of give them a little something, and this is my practice and how I see things, that's where I start to see it. So if I can give them a little bit, almost kind of bargain with them, and it kind of lifts up their spirits a little bit, give them a little more confidence on that one leg, then, I consider that a win. But, what you do, work in your kind of program, that's probably by physiology standpoints is probably superior.
I want to say superior. I want to just throw out there and really just challenge the way we think with this, and not just, throw the standard exercises out there. But why are we trying to do this? You have a rationale. You're trying to improve their confidence in that leg. Obviously, more reps need to be done on that leg. Obviously, it's playing a balance, because you don't want to throw them on that one leg too soon. Like you said, you don't want them shifting using a double leg an exercise. However, studies like that one I just showed you, the ischemia study showed that double leg exercise reduces stress and force on it. So it really depends on your timeline when you're doing these things. And that's why I think it was just a good conversation to have on just some thought process to just really challenge our clinical decision making and clinical reasoning, and what are we basing these things off of? Because like you said, that just because you've reached 3 months doesn't mean you get to go running. And I think that goes in some of these special tests with running and return to sport, such as the Y balance test and the Val sport cord test, the LESS test, lower extremity scale. What, I guess, do you use these things? Triple hop test, how much stock do you put in them? And, are these tests good enough to let people return to sport when we have this data that shows, we're doing something wrong because not everybody's able to return to sport the way they want to, or that we're having a high re-tear rate, typically of the opposite leg. And I know you shared a story of your friend who tore their ACL like 5 times or something. But yeah, what are your thoughts on progression, and what metrics to use to see if people are ready to not only return to running, but return to sport as well?
Sorry, I just had to pour it out. I do a battery of tests, which I shouldn't call them tests. I was actually listening to a performance coach of mine and just calling them tests around the client kind of puts them at unease. And I do kind of recall that with some of my clients, is like, oh, today's test day, let's see if you're ready, those sort of things. And all of a sudden, like, they're not the same person. He's kind of using KPIs or key performance indicators. Like, we're just he kind of phrases it, we're just checking how your performance is of late. So something that I just kind of listened to a podcast and picked up on that. But yeah, I typically do a full battery of things where I do the hop testing, single leg hop, triple hop, crossover hop, and the 6-meter hop. We'll do the tuck jump test. We'll also do a standard vertical jump, single leg. Now I just got vertical jump stuff. We'll do a comparison of quad and hamstring 1 rep maximum testing, and we'll give out the psychological readiness to return to sport test and the COOS, the knee outcome survey. So I think used to be when I came out of school, it was 80% was the criteria. Now it's been up to 90%. Me personally, it's at least 95%. And that's all fine and dandy. I still may shut someone down or hold them off if I don't feel like they are ready. A lot of times they're mentally ready. They'll have great psychological readiness to return to sport. They'll fail some of those physical measurements, or vice versa, which is more surprising because when I give out the psychological readiness to return to sport test, it says it on the top of the page. I'm not even trying to hide it. Yeah. So I think one girl I even gave in the testing was on the bottom, the scoring, and she still gave herself pretty low. So, and then some other times just kind of being around the client, there's just another emphasis of why I think the therapist should always stick with the client through and through, and just kind of be in tune with your client. You pick up on some things of like, is this person really ready or not? I'm seeing them day in, day out. Are they just doing well enough for the test because they want to return to sport? Or am I been seeing things that would suggest that they're not quite ready? So, not that I want to shut anyone down. I'm always, pride myself on getting people as ready as early as possible. But, sometimes I will kind of pull the cord on someone, even if they are doing well, because I think they need more time. And that's something I always explain. I'm like, listen, you have your whole life ahead of you. Obviously, this is more younger people, but what's the hurt in waiting a couple weeks, even if you did pass these sort of things? I'm like, it's ultimately up to you. I can't control you or your body, but you give them your opinion, and by then they should respect it. And I haven't had any backlash from it. So that's pretty much what I go for with all my ACLs in the clinic.
Yeah, I'm with you. Actually, sometimes I pretty much focus on my strength in it and my plyometrics even before I add them to running, because to me, running is repetitive plyometrics. So that's something I want to make sure they're comfortable with landing on 2 feet and on 1 foot and things like that. I'll use the Y balance test. Like you said, I'll use a lot of the hop test, the triple hop test, the crossover hop test, the less test. I'll use the Val sport cord test. A lot of these tests, like you said, like it's test day, but it takes a while to do all these things.
It takes a whole freaking session.
What's up? Yeah,
it takes a whole session. Just hop testing.
Yeah.
If you're doing hop testing the right way, it takes the whole time.
It takes a while, yeah. I'll look at the IKDC form. Like you said, when we were coming out, the hop testing and some of this stuff was said to be 80-85%. I always thought that was too low. I was between that 90-95, and like you said, I think I've even gone to 95%. Like, why is anything less than symmetrical allowed to be a threshold for people to go back to their sport when we know the biggest risk of injury is a previous injury? And if you go by some of the research on the Y balance test, and say what you will about the generalizability of it, it's still predictive of lower extremity injury risk. And if you have asymmetries, you're increasing your likelihood of 2 to 6 time. So, compound that with a major operation and rehabilitation of a major ligament. I mean, why just try and hit, like you said, hit the bare minimum threshold to allow somebody to go on? And then, like you said, you see these people day in and day out, and this is kind of a sports reference, especially when it comes to college players transitioning to the NFL. Do they pass the eye test? Yeah, their numbers can be great. They could have 4,000 yards passing and 30 TDs and 2 interceptions, but do they pass the eye test? Does it look like they can move correctly? Does it look fluid? Does the quality of motion look good? I think we need to develop a keener eye for something like that, coupled with some of these objective testing. I'm not saying just go by your gut. That's not what we're saying here, but I think you compile them all together and you'll know if somebody is ready to go. And then with some of those outcome forms, like you were saying, I try and cover up the name sometimes because, like you said, people will see it and then just circle all high stuff. Unless hopefully you've built a good rapport with them and they say, be honest with yourself. If we have to delay you a month, it's better than being delayed another year because you tore it and have to redo this whole process. Find a way to communicate with your patients where you're honest with them, they're honest with you. And I think if you're honest with them, they're more inclined to be honest with themselves and with you as well. And this is aside from helicopter parents and parents pushing them in. I think that's a whole nother different conversation. But, that's kind of what we're going for. And with the Y balance test, we're looking for a 4-inch difference, less than a 4-inch difference, and with the forward reach and less than a 6-inch difference from the lateral side. So just something to go by with there.
And I can't remember because I don't have Y balance anymore, but I forget there was one. Was it posterior lateral was known to be lower in ACL? I can't remember now.
Yeah,
so
the posterior. I believe it. Yeah, it's named by the leg that you're standing on. So posterior lateral, which is basically the star excursion balance test.
Yeah, we do that.
To really break it down. Actually, they found out the back 3. If you took, forget the Y balance test. If you took the scar excursion test and just did the forward one, the posterior medial, the posterior lateral, that's pretty much all you need to do. So you can kind of take away some of those pointless other in-between steps if you're looking for effectiveness and efficiency with that exercise.
So, I didn't know. Yeah, but Y balance. Do you have it at the clinic?
I don't here at this clinic. I did it at my own clinic, and I did it a lot there. Now I pretty much use everything else, or I'll just put a piece of tape down and measure it with tape, and then add it up and stuff. And you're able to get a feel for that. But yeah, that's something I've wanted to add to the clinic. I just haven't yet.
Yeah, I get the FMS. I was like, I'm going to use it. And the new FMS have that motor control screen or whatever, which can act like a, like a Y balance.
Yeah.
You just have to kind of turn it with them and play around with that. But then ultimately, I just kind of, for those posterior or those lateral components, I've just used the star excursion balance test. But I've been in situations where people have done well on those tests and, sometimes has shoved out. And then the big thing is, at least with me in my practice, and I'm going to, assume that it's probably similar in your practice there, Brandon, is that we hold our clients to, higher expectations than one themselves, but hopefully we kind of, they kind of take our style of approach, but definitely more than the surgeons themselves. So a lot of the time these surgeons will, again, how long does their examination, especially follow-up examinations, especially 6-month or 9-month follow-up examinations, they're quick. Most of them, I think towards the end, they don't even like check range of motion or anything like that. It's like, hey, how's it going? It's good. Okay, good. You're cleared for X, Y, Z. And sometimes you have to look out for the client and say, hey, I do not think you are ready. You're doing disservice to them. And, we talked about that study where so many people have been released to return to sport and they bombed all these return to sport testing. You have to be the one that says, hey, yeah, I know your surgeon says it, and I know you're dying to get back out there because it's probably been at least 9 months since you played the thing that you love the most, but
Mhm.
I really just want to make sure you're not getting hurt out there. So every person that I've done that with, probably at first was probably wanting to key up my car or something like that, but ultimately um, has been fine with things and actually been happy, and ultimately probably thanked me towards the end. Like I had one guy who's cleared at 4 months. He was the best wrestler in his class in high school at the time,
Mhm.
and he was a freak. Again, he was one of these outliers that was way beyond, most, and it was fun to work with. But the surgeon looked at him and was like, "Oh, you're good to go. You can go back if you want." I'm like, just in respect to healing timelines, I'm like, did he remember how far out you were, what day of the surgery it was?
Yeah.
So, take someone who's at his level, I'd be like, listen, no, you shouldn't. And it took some convincing, but ultimately they listened to you. And you gotta understand, you may not have the ultimate say. It's really up to the patient and potentially the surgeon, but you can make a huge influence on these clients for the better.
Yep.
So, yeah, that was my 2 cents into that.
Always, always welcome, always appreciated. I want to say, we talked about our return to sport criteria and some of the tests we use, but that's not even standardized. That there is really no standardization. Let me see if I could pull up
I don't think
that
there's any
article.
validity to them as
Right?
well.
Yeah, it's just a bunch of stuff that has been said, and there's been some studies down. There's this study here by Michael Reinman, Cell. I'm going to butcher this guy's last name. His first name is Justin, so I apologize for not being able to say it. But they talk
Anderson?
about the association between passing the return to sport and second anterior cruciate injury,
Mm-hmm.
and it's really the overall 42% of the patient, almost 43, have passed the return to sport criteria, but 15% of them who passed had a secondary injury. Um, what does that tell us? And hopefully maybe there's some listeners out there who work in maybe a university or hospital setting, and maybe they have access to more technology or more research, and maybe they can provide some insight. But as a whole, I think we need to try and not rush people back and really dive in some research and make sure we're hitting our markers with these patients. And we need to kind of set checks and balances, I guess, to kind of sum up that aspect. Post-op at 6 weeks, at 4 weeks, are they hitting the range of motion? Are they hitting their quad? Are they hitting some basic I guess metrics before, or key performance indicators, as you were saying, before we begin to progress them. And I know it's boring in the beginning, those first 4, 6, 8 weeks with a patient, but that's what's going to set the table for them to do the more important stuff. And I think us as
Absolutely.
therapists want to get to the more important and fun stuff of agility ladders and cutting and loading them up, but we have to remember at what risk are we doing that. And I
Mm-hmm.
know Jeremy and I talked a lot about the quads and knee extension and stuff, but I really think it comes down to addressing the core and pelvic stabilizers, hip stabilizers, and strength, as this article here talks about it. They looked at 15 non-contact ACLs, and what they found was that hip strength for external rotators and abduction was significantly lower in the injured athletes versus the non-injured. And then they had cutoffs based upon body weight strength compared to the body weight, which is something that maybe we should look into, and not just distance or symmetry of distance between left and right, but how about let's look at strength relative to somebody's body weight. As if we look at it, that's what's going to determine what they're stopping. That's inertia. I mean, we're going into physics here, but obviously a larger person is going to need to be able to stop that weight
Mm-hmm.
going full speed and stop and cut on a dime. So maybe trying to incorporate a ratio And maybe there's research out there. I don't know. And I haven't looked to see if there's, some type of research that's been done to standardize what the, I guess, ratio or percentage of strength to body weight should be.
Yeah, I haven't seen anything like that, but no, I wholeheartedly agree with that. You got to think of why they had the ACL injury in the first place. Most of them are non-contact. And we know our PEP programs and everything like that. What do they typically address? And if you're in the sports, an active clientele type of clinic, what do most lower extremity individuals lack? It's probably some hip and core, either motor control or strength altogether. So I took this from a mentor of mine, Sharon. You may have gotten injured, which sucks, but you'll become a greater athlete with what we're doing after all this. Because, we have to address all the things with an ACL, your quad, your knee extension, range of motion, swelling, yada, yada, yada. But we're looking at preventative too. So we're addressing all these hip weaknesses early on. All right, we cooked up your quads in the first 10 minutes because they can't handle anymore. All right, well, I'm finally hitting your hips, which have not done anything in your sport since you played. And then as we're moving to those more advanced drills of like hurdles and jumping and ladder drills and agility stuff, I'm looking at making sure you're having good form. So, that's something that, make sure you encompass everything with your rehab. So ultimately the goal is to prevent it from happening again, or, going down the route of my friend who have had 5 ACL tears.
Yep.
I think it was in a group and some girl had 7. I just saw it this week. I was like, oh my God. At this point, I just stopped.
Stop.
No. I was like, no.
Don't do anything anymore.
It's like, yeah, boy.
But with that, actually, good segue, Jared. You brought that up. At what point do people need surgery? Do all people need surgery? There's something called ACL copers. And I'll just kind of rattle off kind of what the proposed criteria are for somebody who is a coper, which means that they can cope without an ACL for the audience. One is a HOP index of 80% or more for the time 6 meter HOP test. The knee outcome survey, activities of daily living score of 80% or greater, global rate of knee function of 60 or greater, and no more than 1 episode of giving way since the injury. This is the criteria that this article has. You have it?
Yeah.
Is that the same one I have? I don't even know.
They use a similar kind of approach. This is I believe the Udell study.
Okay. Cool.
Of copers versus non-copers.
Yeah. So, I think it's just good for people to be aware that there is this stuff, and maybe you can educate patients of, okay, this has been your X amount of one. Maybe we try a different approach. But there have been known athletes. DeJuan Blair was an NBA player who didn't have his ACL since 8th grade. He made the pros. He was in the league for a few years. He was clearly a coper. But Jared, I don't know if you have anything else to add to that.
With the copers versus non-copers, I think the first blog I wrote for my company was a coper versus non-coper, because I believe Carson Wentz just tore his ACL right when I started Trifecta. So, I believe, it's something that we don't look into enough. And it's really depending on the goals and those sort of things. I think everyone should be given an opportunity of coming in before their surgery. Sure, plan a date. I don't care. Maybe for a couple months. Research says 3 months for to really see if it would work, which most people aren't going to wait, but at least maybe give them a month and they can get an idea of, and the best thing about it is like, all right, let's you tore your ACL, plan your surgery in a couple weeks to a month. We'll rehab things. We'll see how you do, how your stability goes. A big thing I look for is make sure that it doesn't give way. Obviously some strength and those sort of things. So their strength typically returns a lot quicker than a post-op ACL. And then, worst case scenario, all that rehab that you did becomes prehab, and they're going to do a lot better. You restored range of motion, you restored some quad control, yada, yada. But yeah, we have a guy right now who's slated for an ACL repair. Thankfully, COVID came in, pushed back to surgery, rehabbed us with us. And he's like rehabbing once or twice a week with us, and now he's finally, he's like, maybe I really don't need to go through with this. So those are I put them through a similar battery of tests, and I typically will explain to them that yes, you are missing something that's kind of important to the whole knee and the body and those sort of things. Is you should remain active. If you kind of just stop working out and those sort of things, you may start to see loss of all the progress you made. So as long as you're staying active, you're doing your thing, then it should stay asymptomatic and those sort of things. But I try to especially based off their goals. You got extremely high level goals. You're trying to play like collegiate ball or professionals. Maybe that's a little bit different. But every year, if I pull up that, I wonder if that link still works. Let's see.
What link you talking about?
ESPN used to release a non-ACL and ACL team every year. Okay, well, this is complex. Well, it's ruined by injury. Did it change? This isn't it. Where is it? I can find it, but most of these guys on this list, ACL, Terrian's ACL, Jay Williams.
Well, he was in a motorcycle accident.
Yeah.
Almost lost his leg.
Let's see if I can. I'll find it while we're talking. Is ESPN used to release an all non-ACL team of just guys who didn't have their ACLs, which was kind of cool. They release a team of guys who've done it like post ACL, and Tom Brady and Don McNabb did it, Adrian Peterson, but there's a lot of athletes, Hines Ward, Matt Light, John Elway, all played out the rest of their careers without an ACL. So it can be done even at the most highest of levels. So you guys see, again, I think the main thing is if it's giving out frequently, that poses a risk that they may tear the rest of their ligaments and have a multi-ligamentous tear. But that's typically what I'm shooting for, is because again, that usually shakes up people's confidence pretty bad when it just gives out on them all of a sudden. But yeah, that's me.
Yeah, I was just looking at to see if I could find what you were looking for. But right now, the thing on DeJuan Blair came up, but that is it. What, did you look at Slate.com? It was like no ligaments, no problem.
No, I haven't done that.
So it says DeJuan Blair. It names some of the guys you had named before. Philip Rivers. Well, he got surgery. He blew out his knee. Played a couple games before he got surgery. Hines Ward has a missing ACL on his left knee. He was a wide receiver for the Steelers. Like you said, John Elway, not Elway, Marino.
I think Elway did it too.
Oh yeah. You're right. It was Elway, not Marino.
So yeah, I mean, again, it can happen, but
Elway, Mantle was running out in the outfield and tore his. He landed in like a drainage. He tripped over a drainage in the Yankee Stadium, and that was back when ACLs would have ended your career because it took a year in the hospital. Joe Namath apparently didn't have one. Bob Lanier, Thurman Thomas, and that's the end of that one. Anyway, we're getting sidetracked here.
Yeah, a little bit.
So on there, we'll wrap that up.
Yeah, I just finished my drink, so.
Hopefully this was a good podcast for everybody. You guys found a lot of golden nuggets and at least questioned maybe some of what you're doing, or just learned some stuff that you can add to what you're already doing. And that's pretty much it. Jerry, anything else to add?
No, that's all. And yeah, if you have any questions or debates or need advice of any sorts, feel free to reach out to us at Manips and Sips on Facebook and Instagram. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. Thanks for listening in, and cheers, everyone.
Cheers, guys.